Kia ora everyone, my name is Dr. Ben O'Keefe and I'm the Director and Co-Founder of oDocs iCare. It's a real privilege to be able to talk to you all today, even though it is virtually, but about oDocs and what we're trying to achieve, which is around creating the access and the affordability of eye screening tools for all New Zealanders. Hopefully by the end of the talk as well, you'll get a bit of an insight into what we think the future of ophthalmology is going to be within New Zealand, especially around the referral process. Where it's going to lead towards, we believe, online platforms, virtual platforms, and the use of teleophthalmology. So a bit of background about myself. I'm a non-training ophthalmology registrar and locum. I've been locuming for the last few years, mainly out of the Capital and Coast DHB and now some Marlborough DHBs. So for any of the Wellington-based optometrists that recognise my voice, I'm sure and I hope that I was very kind to you on the phone when you were referring to the hospital. Because I certainly respect and enjoy and love the work that you do, treating patients in the community, acting as our gatekeeper, and making appropriate referrals to bring patients in. So as oDocs iCare, we started as a social enterprise where we looked at low-cost technology, which was based around smartphone adapters, so that people could actually have their anterior segment, their posterior segment, and their retina viewed without relying on, tertiary centre or, optometry-based, expensive equipment. Mainly looking at places within, third world countries that didn't have access to those types of centres. This started back in 2014 by myself and Dr. Hong. So Dr. Hong just finished his race exams. And back in 2014, we saw that area that I just alluded to before, where, there are countries in the world that, obviously in New Zealand, we take for granted, the access that we have, to eye health, even though it isn't perfect, which I'll get to later on. So we saw that, especially with the advent of smartphones, and the technology behind smartphones and the camera and the image quality that was able to be taken, that really, the access that we could provide was really, it was very close. We just created these devices. So that, people within these countries that potentially didn't have access before, if we could create these devices that could attach to your smartphone, well, all of a sudden, images, videos of the anterior segment, the posterior segment, the retina could be taken and that could be referred on and could be used, which is a lot better than anything that they potentially ever had before. So our goal or our mission was to end preventable blindness by creating those, tools and devices, with the idea that and the understanding that 40% of visual impairment was from preventable causes. And again, a lot of it was around accessibility and affordability. So especially in New Zealand, we wanted to try and create these devices that democratized eye health. So it started very early on by just simply getting a 20 diopter lens, attaching it to a plastic arm to your smartphone. And what we did is we created an open source device, and it was free. So it was 3D printable. So as long as you had access to a 3D printer, which was becoming very accessible now and very cheap, you could be anywhere in the world and you could download our original device, we can see in the bottom left corner there. And you could download it for free, and therefore you could access and take images of the back of the eye. So this is what we did at the start. And it really, once we saw the success of it, once we saw people actually downloading it for free and we were getting feedback that, they could actually use it and it had real benefit for people, especially who had mobile clinics, especially people that were working in Africa. They really loved using it as something, as a way forward, as a step forward to actually be able to see something that they weren't able to do before. They weren't able to actually have a look at the back of someone's eyes because they didn't have access to the type of tools that are required to be able to do that. So we saw that, and it gave us really good hope that this was something that, is going to work and that people would like. And we continue to create products. And I think, our goal now is to really try and replace the other image that you can see Dr. Hong using there, the direct ophthalmoscope. As you know, it's probably not a secret. I don't think any ophthalmologist ever uses that. And I think for many GPs, it's a relic that just sits on the wall. It's a very tough device to use, which I'll allude to later on as well. And so it really led us to look at our own backyard. So within New Zealand, we saw that there were some conventional problems that we thought were happening within, the referral pathway in New Zealand. The eye health system within New Zealand. So these were conventional things that had been happening within New Zealand for many, many years. And we thought, well, potentially there's a time for change here, especially for people that live rurally within New Zealand who potentially didn't find it as easy to access the eye health or the eye care that they required. And by doing that, we identified that there were sort of five main issues with the conventional system within New Zealand. A lot of it was around limited workforce in terms of ophthalmologists, the wait time that was required, the ability of a specialist to actually have the equipment available, or even just a GP to have the equipment available, the confidence of that initial diagnosis for the GP, and then I guess the unnecessary referrals that were led from the GPs. So this conventional system, potentially, and what it has led to, I guess, in a tertiary hospital is that these tertiary centres have a large backlog of patients because the system beforehand for the patients to be able to get there through the GPs, through the optometrists, could be better. And it's something that, we really identified as something that if we could improve that, it could really improve that backlog and could really improve the safety for patients because they didn't have to wait so long and they could actually be seen by an ophthalmologist. So in terms of limited workforce, so there is a shortage of doctors within New Zealand. There's a shortage of ophthalmology registrars. What there is really a shortage of is actually specialist ophthalmologists, actual consultants in New Zealand. And in New Zealand, there's only 169 specialist ophthalmologists. And of those 169 specialists, the majority of them live within the North Island. So the distribution of ophthalmologists around New Zealand actually isn't uniform either. So just by luck, depending on where you live, you may have access to an ophthalmologist, you may not. If you don't have access, you're going to have to travel. And I think for those, I guess, patients, and then also yourselves, optometrists and GPs that live in the South Island, there's a heavier reliance on yourselves to be able to manage, I guess, diagnose and then treat patients who, potentially would be an easier referral to a tertiary centre. But, because you live in Wanaka, or because you live on the west coast of the South Island, because you live on the east coast of the North Island, you actually don't have that easy access to be able to get to that tertiary centre because it may lead to a long wait time or a long drive. And that's one of the big issues, is that potentially patients, even though we're a small country in New Zealand, there are patients that will need to travel 2 to 3 hours because they can't directly refer themselves to an ophthalmologist, obviously publicly. They're going to have to travel if they need to be seen by a GP. And that's the current system now, isn't it? So, we go through the gatekeepers, optometrists, GPs, rural practitioners, and that decision needs to be made on whether they actually can go to that tertiary centre or not. And I guess so that access and the affordability is I guess, something in terms of the streamlining of the process that we want to try and achieve with the teleophthalmology platform as well. Now, of those rural centres, GPs certainly don't have the fundus camera. Fundus cameras, we know, cost $30,000 to $50,000. I'm not sure every optometrist has that either. So, if we really want to get a good review of the fundus, if they're not going to be using the direct ophthalmoscope, which we know is tough to use, there's a steep learning curve around actually using it. GPs don't see eye patients every day, so they're actually not getting to practice using it every day. And because they're not going to spend the money to get that fundus camera, the availability of that specialist equipment is really, really difficult unless you're not in an optometry setting that has it, or you're actually in a tertiary centre that actually has those devices as well. So that's another current problem. And because we're basically hamstringing our GPs by giving them devices that don't really work in terms of the direct ophthalmoscope, it's not surprising that 80% of GPs aren't confident in performing retinal examinations. And look, you may get GPs that are confident actually using the direct ophthalmoscope, but then it comes down to, okay, how correctly and how accurately can they describe what is going on in the back of the eye, the macula, the optic nerve, the vessels. That's something that, it takes us time as ophthalmologists, as registrars, as junior doctors, I'm sure optometrists. It takes you time by seeing patients constantly, day by day, to actually get good at that. And we're expecting our GPs in a rural setting to be able to do that too. So, that's very, very difficult when they don't have the tools to be able to access it. Therefore, they don't have the confidence in actually being able to, give that initial diagnosis. And that's actually going to lead to unnecessary follow-ups in terms of referrals. And, the GPs do a great job, and I'm just using them as an example. But on the phone, when we're having to decide whether a patient needs to come in basically from a referral online, using that phone, it's going to be difficult for us to say no. So, the majority of patients, we're just going to have to get into the clinic, and that's going to backlog the clinic. And a study showed that actually we could decrease this and streamline it by 40%. So that's a huge amount of I guess, time that, will go back to the ophthalmologist, will go back to the registrars to be seeing patients that are waiting in the clinic, and they actually wouldn't have to wait as long either. So, those are 5 of probably the issue we're trying to change. And I think we can do that by creating this iCare ecosystem, by creating a connection between GPs, by creating a connection between optometrists, eye health practitioners, and the tertiary centres. And we can do that by using our devices, using the smartphones that you can attach them, by logging into the teleophthalmology portal, and then having a specialist at the other end. It makes iCare accessible, affordable. It makes it very efficient and a lot more effective than I think what the current model is doing. And so as you can see, this is the current model, and it's been working well for many, many years. But the main problem, I guess, is the issue around, the question around priority. So for GPs, and I think, optometrists, you do a fantastic job as well, and actually you make it a lot easier for us around your descriptions, around, when a person can come in or not. But if you do have a GP or a rural practitioner in the rural setting who's actually calling us up and trying to describe something to us, they could do everything right. They could do the visual acuities, they could check RAPD for us, and it's fantastic. They could even install some fluorescein and use a blue light that they might have on a slit lamp there. But it's really difficult because I'm not really sure when I'm taking a phone call whether that abrasion or the fluorescein positive is just an abrasion that can take some chloramphenicol ointment and it can, the patient can go home, or are there actually infiltrates underneath that abrasion that I need to see urgently? For an ED doctor in the same setting who doesn't have a specialist ophthalmologist in the hospital, so we're in a rural hospital now. So yes, they may have a slit lamp, and they can use a slit lamp adapter eventually, but if they don't have any of that, they can actually they can tell us that there is cells in the anterior chamber. So they can do a fantastic job of that, but can they actually tell me if there's any hypopyon when you're not actually seeing that day to day? It can be quite difficult. How many cells are actually in? What's the degree of severity? So all this detail is really important for us to get. You can get another setting where there could be disc swelling, or how much disc swelling? Is it bilateral? So all these questions are things that currently we're having to actually describe and ask, and then decide over the phone to decide whether that patient needs to come in urgently, or whether that patient just can be seen routinely, or whether that patient doesn't need to come in at all. So all these things are really important, I think, for the safety and the efficacy of patients and their care. So because we can't really be sure over the phone, it's safer for the patient, it's safer for us, it's safer for, I guess, the confidence for the GP as well, just to bring that patient in. And 9 times out of 10, that's what I do as a registrar, because I could never be 100% sure, what was being described in terms of, the safety aspect. So what that leads to is backlog, it leads to travel time, and it leads to a lot of, I guess, waiting time for that patient, which does affect, I guess, how affordable and how accessible the healthcare system is right now. So I guess with the advent of COVID, what's become more acceptable is the use of telemedicine and online platforms like Zoom, like DocsME, and that's been a fantastic, I guess one of the benefits of the pandemic, where it's really pushed the hospital and I guess the DHBs to move into a space where, we need to look at all these opportunities around us to try and still create an environment where we can look after patients correctly. And I know a lot of GPs are using it right now. I know a lot of physiotherapists, for example, are using it to do clinics too. And patients are really accepting of it. People are accepting of it as a way forward in the future. And I think, it's a huge opportunity for us in medicine, because we know that in ophthalmology, it's such a visual type of medicine that it's, I think it's been crazy that we haven't been able to, advance further afield in this beforehand in terms of using pictures, in terms of using videos, and only having to rely on printouts that we get, or actually relying on the written notes that we use in clinics. So the fact that it's allowed us to do this is a really, really positive thing, because now what we can do, even though Zoom, even though DocsMe, they're really good for health, it's not specific actually to the online platform that we can create using the teleophthalmology system at oDocs iCare. So the teleophthalmology system is a portal that we've created so that you can actually log in if you're the GP, if you're the optometrist, and using one of the devices, you can load that on and have the patient in front of you. You can get a really good clear image of the back of the eye and a video, and you can log on and actually have that consult where the consultant or the registrar is on the other end and actually seeing what you're seeing, or seeing what the GP is seeing of the patient's anterior segment or the retina. That's great because we can then make an actual diagnosis and be more specific around whether that patient needs to come in urgently or whether that patient can actually be referred at a later date. So all that whole thing around this environment, this ecosystem that we're really trying to create is around smartphone technology. It is around the telemedicine platforms, and I think it is around the acceptability of that happening within New Zealand, I guess, especially in those people or those places that don't have the access to be able to get to those tertiary hospitals so easy. And that's what we'd like to do. We'd just like to connect everyone. So we'd like to connect other hospital doctors, ward reviews, mobile clinics, rural practitioners, medical students, all to be able to log into this platform and then be able to have access to a consultant, have access to the registrar that's on call, so they can immediately get answers. And I think by the fact that we're taking images now and taking videos, when we're comparing those patients on a day-to-day basis or week by week, or even a non-routine review, or you're seeing someone 4 months later, by actually seeing images of how the subepithelial infiltrate has gotten smaller, actually looking at the images of the diabetic retinopathy, the changes, being able to compare that is a really, really, I think, a positive thing for patient in terms of the reviews of what we're trying to do in the future. And I think what it does is it combines a lot of what we're, I guess, stepping into already in terms of, for example, the diabetic screening. I know a lot of the referrals from optometrists do have images now, and by combining all of that together, I think be able to do online clinics as well is really, really going to provide a good benefit to patients and actually the whole system as a whole. So, for example, here's an example of potentially how it would work, where a patient would go to their GP, and what the GP would do, or the optometrist, for example, if you had a slit lamp adapter for your smartphone, you'd actually log into the portal, and you'd actually be able to quickly see the ophthalmologist at the other end. And what the ophthalmologist or that registrar will be able to do is see exactly that. So I can actually see the anterior segment, and we can also get a really good view of the fundus of the back of the eye as well. If we're focusing on the optic disc here, you can see the macula and obviously some retinal hemorrhage there too. So that detail, I think, is really important for us. And as the technology advances, I think as the devices advance, as the platform advances, this whole process will become so streamlined and will really, really save time in terms of the whole process of what currently has been done now. And the benefit of this is that I can actually see that, okay, this patient needs to be referred immediately. This patient needs to be seen. They don't need to wait, and it's going to save travel time. It also means that the patient that actually it was just a smaller corneal abrasion, that there was no infiltrate, they don't need to travel into the hospital. I can be sure, I can give confidence to the GP that they can be treated at home and maybe seen in their own clinic in a week's time, mainly because visually, I can see that versus potentially not being so sure on the phone in the description. So this is relatively new for what we're trying to do, and we've done a few showcases in terms of proving teleophthalmology can work. This was myself in Auckland using 5G at the Spark Starter Fund Day, and it just showed. So we logged into the teleophthalmology portal. I was acting as, I guess, the registrar who would be at the other end, and we had Hong in Dunedin. So Dr. Hong had a patient, and he had a question around the optic disc and the vessels around that and whether there was swelling or not. So sitting in Auckland, I could log in, they could log into the platform, and I could get a really, really clear view of the optic nerve of the disc. And confident that there was no swelling in that patient. So, that just shows how streamlined it can be and how the access can be just like that in terms of being able to get a specialist opinion and, therefore making a better plan and safety for that patient. This is a really good story of Jennifer and John. So Jennifer had microbial keratitis, and what Dr. Hong did in Dunedin, so they live in Wanaka, he was able to teach John how to take images of the anterior segment of the eye with one of our devices. And so Hong was able to review that daily, and it just meant that Jennifer and John, didn't need to travel back and forth from Wanaka on a daily basis. It meant that, therefore, clinic appointments are free for other patients that could be seen in the Dunedin Eye Clinic. And it also meant that Jennifer didn't need to stay in hospital either to be seen, because this could be done safely and appropriately at home. And they really enjoyed that. And it just showed the success of doing something simple like that, using the technology that is available. So where we see ourselves and what we're trying to do is, using this teleophthalmology platform, we really want to try and get the DHBs on board. We want to show how effective it is. And so we've done some trials using between DHBs, so Dunedin Hospital, Queenstown ED. We're starting one between Dunedin and Wanaka now, just to show that, look, this teleophthalmology platform, using the devices that you can attach to your smartphone, is going to really increase the accessibility that GPs have, that potentially optometrists have if they don't have access to certain devices to be able to contact the specialist, and therefore patients who have issues with their eyes can be diagnosed and seen. And I think by doing those existing trials, if we can go to DHBs and prove that this is in a safe and effective way to actually change the whole iCare ecosystem, they're going to really see the benefit in that, because if they were certainly just coming from a cost side, it's definitely going to save them in terms of the amount of patients that are being seen, the amount of patients they're having to wait, and I guess the inappropriate time patients are not being seen in because of the clinics that are just full. And we all know the system. I'm sure you've all been on the end of a phone call or referral to a pretty stressed ophthalmology registrar that was on call because their clinic's overflowing. But that is the system right now. The iCare system is overflowing, and we definitely need to try and work a way to be able to improve that so that patients can be seen and can be treated safely. And I think this is definitely one of those ways. In terms of the future, so if we look at the teleophthalmology platform and the products and the things that we're using to attach to your smartphone, it's amazing once we get into the realm of getting things online and getting these virtual consults. Once we start talking about images, once we start talking about taking videos of the back of the eye, then we can quickly move into other technology that's available, especially around artificial intelligence. And I think AI is a really, really important future skill that's going to help ophthalmology in terms of diagnosis, in terms of even triaging. I think the fact that we could actually take photos of the retina and have an artificial intelligence system or algorithm that could pick up how bad the diabetic retinopathy is, even the anterior segment, the size of the microbial keratitis, is there infiltrate, is there a hypopion, how many cells are in the anterior chamber, all these things, that with the advent of AI, all we need to do is create algorithms to be able to do that. And it's really going to help GPs, it's going to help the referral system, it's going to help the prioritization of patients as well, because it's going to create another, I guess, safety net that's going to help the ophthalmologists, the registrars that are obviously doing the prioritizations. And therefore, because that will be streamlined and quicker, they can get back to seeing patients. And we can, work on top of that backlog that's happening within the system right now. So it's a really exciting future, I guess, once we get into this area of using teleophthalmology and using, systems that we're trying to put in place at oDocs. So other small things in terms of the future, one's around, continuing to create affordable devices so that people have access. So we can do autorefractors. We've got a smartphone-based cross-linking devices. We know cross-linking is a really good treatment for patients with keratoconus to limit the progression of keratoconus and hopefully keep some of their eyesight. But again, the problem, like many other aspects of ophthalmology right now, is that the devices that do cross-linking are extremely expensive and only found in tertiary hospitals. When really it's actually, it's UV light and some special drops. So what we're trying to do is actually create a smartphone-based cross-linking device as well. So potentially in the future, GPs can do the cross-linking, epithelial on. Optometrists may be able to do the cross-linking in the future as well. And in line with that, red reflex-based refractive error predictions in our devices is something that we can do as well. And an example I'll quickly just show here. So that's an image taken with the retinal camera that we have, and you can see the refractive error that it can pick up there as well. So for us at oDocs iCare, it's really important that obviously we increase the accessibility and affordability of iCare for everyone. And we're starting in New Zealand. We initially thought that it was going to be important for third world countries, but we realize that there are issues here too. And I think there's massive opportunities that we have within New Zealand to really try and change the dynamic that we're so used to with the advent of smartphones, with the acceptance of virtual clinics. I think teleophthalmology certainly is something that's going to be important for us in the future. It's definitely going to be the way forward, I think, for us in the future. And I think, through our experience, I'm sure everyone in the room, the experience of understanding how important images and videos are for diagnosing ophthalmology conditions, you can truly see how the idea around this benefit is going to help patients in the future. So in terms of oDocs iCare, that was really the chat that I wanted to talk about today. So I appreciate you all obviously sitting in and listening. I'm looking forward to seeing how this develops in the future. I think optometrists will be a big part of it. And hopefully I look forward to, instead of maybe talking to you on the phone, maybe we can have a live consult one day using a teleophthalmology platform, which I think is, as I said before, is going to be exciting for us. This is something we're trialing. This is something that's new for us. So, we're looking to grow in this area. We're looking to try and make it the best that we can to make your lives easier and also better for the patient as well. So please, if you ever start using the devices in the future or the platform, we're really open to feedback. We'd love to hear, what you think of it so that we can make improvements so that the whole ecosystem can get better. I think that's me right now, and I think I'm going to log in live to answer any questions that you have. But yeah, from my point of view, from right now, thank you very much for taking the time to listen to me. I hope your conference has gone really well, and all the best. Thanks very much.